This week on the BackTable podcast,
some of the treatments that we can do can cause pain related to the bones. Like after radiation therapy, you may have a compression fracture that's not necessarily cancer related, but still needs to be treated. And then there's also something called existential pain, which is like the knowledge of your cancer and the kind of the pain that you get associated with that, and can amplify the other sorts of those pains. And so the first thing we like to think about is classifying that pain. Is this a visceral pain that we need to either have us do a percutaneous drain or stent, or GI has to go in a stent, relieve that obstruction and relieve the pain? Is this a neuropathic pain, and do we need to do some sort of neuropathic intervention like a celiac neurolysis or cryoneurolysis that we can talk about? Or is this a somatic pain, right? If they have a vertebral compression fracture, we can do a celiac block. That's probably not going to do anything.
Hi, everybody. I'm Greg Botta from UC San Diego Moores Cancer Center. I am the GI Medical Oncology and Pancreas Cancer lead, and I'm here today to talk a little bit with my colleagues about complications in pancreas cancer.
Hi, I'm Rebekah White. I'm a surgical oncologist also at UC San Diego.
And I'm Zach Berman, an interventional radiologist at UCSD as well.
Thanks so much, guys, for joining us today. So I think the biggest part about pancreas cancer is the presenting symptoms that our patients have. And usually that brings them into the emergency room is pain, whether that's abdominal pain or back pain. And I think this is one of the first complications we have to deal with. Zach, I was hoping maybe you could talk a little bit about how an interventional radiologist would deal with pancreas cancer pain and what techniques are available.
Yeah, I think it's a perfect place to start. The field of interventional radiology, and there's a subfield of it called interventional oncology, that has really started to expand in their thought process of how we think about this. So one of the areas we think about in interventional oncology is palliative sort of thing, not necessarily like palliative care, but how do we help patients with pain? And so we've kind of started to learn or adapt or steal some of the knowledge that the palliative care doctors have taken to figure out how we can treat the patient, right? And so there's many different causes of pain. There's the visceral pain, right? You have a tumor that's in your pancreatic head that's perhaps causing obstructive, pain. They're obstructing the bile duct, and the distension from all that can be quite painful. There's also neuropathic pain. There's pain associated with the nerves in the area. There's somatic pain, which is usually like we think about bones and stuff like that. And so if you think like a bone metastasis would be one, and as we'll kind of discuss as we further go along with our talk as well, some of the treatments that we can do can cause pain related to the bones. Like after radiation therapy, you may have a compression fracture that's not necessarily cancer related, but still needs to be treated. And then there's also something called existential pain, which is like the knowledge of your cancer and the kind of the pain that you get associated with that, and can amplify the other sorts of those pains. And so the first thing we like to think about is classifying that pain. Is this a visceral pain that we need to either have us do a percutaneous drain or stent, or GI has to go in a stent, relieve that obstruction and relieve the pain? Is this a neuropathic pain, and do we need to do some sort of neuropathic intervention like a celiac neurolysis or cryoneurolysis that we can talk about? Or is this a somatic pain, right? If they have a vertebral compression fracture, we can do a celiac block. That's probably not going to do anything. We need to do something like a kyphoplasty. So we like to start by diagnosing what kind of pain it is.
Yeah, thanks so much for bringing that up. I think, multiple times patients will come in right off the bat and they'll say, I have this pain, and it's just a catchphrase for everything they're feeling. And we know in pancreas cancer, it's a multitude of issues, from the inability to digest to the inability to have any type of pain control with either things that are anti-inflammatories or opioids. And I think diagnosing that and separating it out is vitally important, so you can kind of get to what the issues are. And of course, the idea that everything is cancer pain. And sometimes patients can have just normal pain issues that have nothing to do with cancer. Becky, from a surgical oncologist perspective, how do you look at pancreas cancer pain, and how do you talk to your patients about it, and what interventions are available for you?
So I guess the patients that I'm more likely to be seeing in clinic are those with localized disease. So first I'm thinking about, of course, looking at the imaging and determining whether there's something that needs intervention to address their pain, to address the cause of the pain. But, assuming it is something related to their tumor, I think the key is using multimodality therapy. Of course, many of our patients do need opiates, but we try to utilize non-opiate medications as much as possible. Since there often is a neuropathic component, I'm a big fan of drugs like gabapentin, and I often prescribe those for my patients even when I first meet them. Perhaps some judicious use of nonsteroidals, and of course addressing any enzyme insufficiency, because I often do think that a lot of their pain is actually can be related to gas and digestive issues.
Yeah, and bloating,
Yeah.
And I think that's really important. The complications of pancreas cancer, the pancreas, its location in the body, its anatomy is right in the core of our being. And therefore, I usually say it's the grand central station of organs. We have blood vessels going through, we have digestive enzymes, it's sitting on a nerve bundle. And because of this, these different types of pains that we're sensing can be multimodal. Zach, so what types of techniques would you be able to assist a patient with locally to try to decrease that sense of pain that they're experiencing?
Yeah, so let's take neuropathic, because I think that's what most of our patients are going to be experiencing. It's targeting the nerves, right? And so figuring out which nerves are the ones that are kind of pissed off, for lack of a better word, and treating those. And so usually, given the location of the pancreas, it's going to be traditionally what we think of as the celiac neuroplexus, right? So the nerves follow the arteries, and so it's the arteries on the celiac artery that we think about. But I think more and more we've thought about tackling a little bit closer, one plexus up. And so most of the time, if it's neuropathic, we think about the splanchnic nerves. And if you remember, probably from your med school anatomy days, you probably had to memorize these things, the greater and lesser and everything else like splanchnic nerves. But long story short, it's just the nerves that run along the aorta, right? In the retroperitoneal space, the nerves that go in the aorta. And so we like to target those. There's a few ways you can do it. The first way is like a test block where you inject a local anesthetic that lasts for about 18 hours or so, bupivacaine, and that allows you to do a test to see if the patients can get any relief. We generally do like to do those for non-malignant causes of pain. It's just unfortunate for the patient, if they're having abdominal pain, to have to come to the procedural area, lay on their stomachs, get, they're small needles, but they're still needles put into their body, injected, then have to come back and do it again. If it's non-malignant, we like to do that test first because we don't want to do something that's, quote unquote permanent or at least semi-permanent. But if we have a huge tumor in your pancreas and it's right on the nerves, that's probably the cause of the pain, right? So we feel a little bit better about doing a more permanent block. Mm-hmm. And there's two medications you use for the permanent block. The first one is ethanol. So it's actually 200 proof or 100% ethanol dehydrated. And the second one's phenol. I think for a variety of different logistical issues, most people don't use phenol anymore, and they do prefer to use just the dehydrated ethanol for their block. And so,
when you talk a little bit about permanency, what are we expecting with these blocks? Patients, I think, come to us and they have variable length of time. What is your take on that? What do you tell them?
Yeah, so I'm sorry I have to drag you back through med school again, but so you inject the ethanol. The ethanol denatures the proteins around the nerve axons, right? And then you get axonal injury, and then the nerves, quote unquote, die. But they don't die because you haven't treated the cell bodies, right? They undergo something called Wallerian degeneration, which I'm sure it's been years since you've thought about this, right? Where the axon dies back to the cell body and then regrows, right? And so they say about 1 millimeter per day is how fast this happens. So it does grow back. And if you do the math, it lasts for about 3 to 6 months before you have a new nerve. And the hope is for some of our patients that when the nerve grows back, it grows back normal, where the previous nerve was the injured, whether it be from the cancer or the radiation or whatever. But 3 to 6 months is usually where we see most of our patients having the benefit, and it's very easily repeatable.
Oh, that's great to hear. Yeah, I think a lot of times our patients are always trying to say, if that pain goes away, I can live my life. I can actually go do the things I need to do. And, to try to get to that issue, obviously, is the reduction in the tumor. And we try to do that, at least at UC San Diego, with kind of a sandwich approach or a perioperative approach where we do systemic therapy and surgery and systemic therapy. And I think a lot of our patients will get improvement just from starting treatment in their pain. Becky, I think a lot of people always say, all right, as I prepare for surgery in the post-operative period, what is my pain going to be like? How long am I in the hospital for? What are some red flags I need to be aware of from complications from the surgery or increases in pain? Could you talk to us a little bit about that?
Yeah, so I usually say things like, we're going to be taking away one pain and giving you another pain. I mean, it's going to be different than perhaps your visceral pain. Every patient's different, of course. I think we do a pretty good job of managing pain in the immediate perioperative period. At least at UC San Diego, we pretty aggressively utilize regional anesthesia, so either epidurals, or spinals, depending on the situation. So I think we do a pretty good job of controlling that very early postoperative pain. But, patients will continue to have somatic pain from their incision. And of course, they may have some pain related to their digestive issues that can last for weeks. I usually tell patients that they probably will need some type of opiate pain medication for at least a few weeks after surgery, and that they're not going to get back to normal for months.
Yeah, I think it's really important letting the patients know what the expectation is, after surgery and specifically kind of the long-term issues. We know that patients will come in already with a pancreas that's injured, so they're going to have issues with blood sugar or diabetes, but also enzymes. Something the pancreas does as an exocrine organ is distribute enzymes for digestion, and you may need supplementation for that over your life. And then also the surgical replumbing can cause its own issues. Can you talk a little bit about Whipple anatomy and issues that can cause with that?
Yeah. So I think, first of all, starting with the issue of enzyme supplementation, I think until maybe a few years ago, I think we greatly undertreated exocrine insufficiency in our field. I think there's increasing recognition that this is very prevalent in the pancreatic cancer population. Even if you aren't having those classic symptoms of greasy, oily stools, steatorrhea, you likely do have some degree of exocrine insufficiency. And it's amazing when you prescribe enzymes to patients, how often they will say, oh yeah, I actually feel much better. And, that helped that pain I was having. So I think we use enzymes liberally in the both preoperative setting and then in the postoperative setting, because as you mentioned, after a Whipple, of course, you are replumbing patients. You can't restore exocrine insufficiency. You're taking out, anywhere from a quarter to a third of the pancreas, and it's never going to get better. So if you were needing enzymes before surgery, you're going to need them after, and you may need them even more. Then you're also adding in the important issue of endocrine insufficiency. Now, this is a little more complicated because you would think that we'd always make diabetes worse, but we don't. Sometimes we actually make diabetes better when we take out the tumor, and I think that's a fascinating concept. But I do counsel all my patients on the risk that we might make their diabetes worse or give them diabetes. And I think it's really important as a surgeon that you're monitoring these issues in the postoperative period.
Yeah, I think that, being at a comprehensive cancer center and having a pancreas cancer program, we're very blessed to be able to do these things right off the bat. We have patients come in for their first consult and we're already telling them to take your enzymes with the first bite of a meal and make sure you have enzymes, make sure your pain is controlled so that when you're going through your treatment, you're capable of doing so without stopping and starting. And I think a lot of times having that kind of comprehensive multidisciplinary approach with you and our rest of our colleagues is so vital for the outcomes to be so important.
Speaking on that topic, when do you get a nutrition consult, and when do you loop them into the plan?
Yeah, I think, at our center, we're blessed to have basically a nurse practitioner, Dallas, who basically is the gateway for all of our patients who come through the program. And off the bat, we have a nutrition consult day one, enzyme replacement day one, talk about pain and how we're going to get to that day one. And I think that doing that at the first onset and encounter is just so important because, as Becky brought up, some of these pain issues are easily reducible with just intervention with an oral enzyme pill, something that you could even get off of Amazon if you needed to. So, honestly, I think that starting day one is so important for our patients. I think that, post-operatively, obviously there's prophylaxis for clotting. Mm-hmm. And clotting and bleeding in pancreas cancer is a huge issue. And we never quite know which way the pendulum's going to swing. Can you talk in the immediate post-operative period a little bit about your anticoagulation strategy? And then maybe we can shift a little more about what happens when clots do happen.
Mm-hmm. Yes, another thing I often say is we're more afraid of clotting than bleeding. Not to minimize the risk of bleeding, but blood clots are a major cause of death in this patient population. So, right, we start using pharmacologic DVT prophylaxis even before surgery. We routinely give sub-Q heparin before surgery. And then right after surgery, we generally start Lovenox every day. And then there are very strong data that treating patients with prophylactic 4 weeks of Lovenox actually improves outcomes. So we send all of our patients out of the hospital with Lovenox injections, and we warn them about this prior to surgery so that it doesn't come as a shock.
No, it's so true. I think that most patients with pancreas cancer have a huge increase in having a clot, a DVT, pulmonary embolism, and these can be life-threatening. A bleed can be life-threatening, but maybe not as acutely.
Correct.
So we can always kind of give blood
fixable.
back. Right. So I think that that's kind of what we're trying to stop. Some patients will even come and say, should I prophylactically be on an anticoagulant? And to that degree, there is some data, from the Cassini study showing that might be something beneficial if you outweigh the risks and benefits to getting patients on. I think we have a low threshold. If we see any thrombosis, we usually try to start people on anticoagulation, usually oral, so they don't have to inject themselves with low molecular weight heparin. When we do get into that clotting risk, though, I think it causes a lot of issues with lower extremity swelling, abdominal swelling, and it may not be from the cancer cells. It may just be from backflow or retrograde flow. So, Zach, in the interventional space, I usually say, hey, can you help out with this patient? Is there a way for us to remove this clot or to stent them? Can you talk a little bit about techniques to help reduce that clot symptom and edema?
Yeah, of course. So again, I guess I'm going to keep harping on the med school days, but Virchow's triad, right? So you think about what causes clotting in the first place. There's some things we can modify in the triad, and there's some things we can't, right? They're hypercoagulable from their malignancy. We can try, anticoagulation to help with that, but a lot of it's flow, right? Reduced flow. Whether it be in the portal vein, because of the tumor itself, either occluding the portal vein, or post-surgical, sometimes you do get inflammation around the portal vein and getting compression from that. Or if it's the IVC, whether it be from the liver metastasis kind of directly compressing on the IVC, or again, just the inflammation from that whole area kind of narrowing and occluding the IVC. So again, a CT scan to first diagnose what the problem is, because it's going to be a very different treatment, whatever it is. And I like to think of ourselves as glorified plumbers, because that's how I think about the thing, right? You need to get blood coming into where it's coming. You need blood going away from where it's going. And so once those two are open, like you have a good SMV for the portal vein and a good intrahepatic portal vein, it's just right where the pancreatic head is, we can place a stent in there, right? We can relieve the obstruction in that place. And then same thing for the IVC. If it's just compression, we can put a stent in there and kind of relieve that obstruction. And we've had a pretty big revolution over the course of maybe the past 5 to 6 years on our venous stents that are available. They've undergone, improved technology, and the materials that they're made out of have been improved, so they're more durable. But then also, if it's an acute clot, we also have newer generation around the same time of the ability to suck the clot out, right? And so before, I know when I was in training, if someone came in with a DVT or the IVC was occluded with clot, you put them on a TPA drip, and they went to the ICU for 24, 48 hours, getting 1 milligram of TPA an hour. Now you can imagine someone who just had a Whipple procedure, that's really the worst time. You want someone like systemically on TPA, right? And so traditionally, we didn't do anything for that other than anticoagulation and prayer. But now that we have these thrombectomy catheters, it's made our lives a lot easier to actually go in and take acute clot out. So we've been a lot more aggressive about that, right? So optimizing the inflow, optimizing the outflow, and then stents, right, where the issue is to kind of keep everything open.
Yeah, and I think that, getting those clots out are just so vitally important, because once that blood flow is restored, a lot of those symptoms that our patients are having with the lower extremity swelling and the abdominal distension, are relieved. And in fact, it's also, inhibitory to get to surgery with those types of things going on as well.
Yeah, I think that's an interesting point, because we often see patients who have near narrowing or near occlusion of their veins when we first meet them. And so, I think there are definitely patients where we have treated with anticoagulation preemptively, because if that vein becomes thrombosed, that will preclude any type of resection. And then there is definitely a body of literature on putting in stents in that situation to try to restore flow and make them candidates for surgery. So I think engaging our IR colleagues in this field is important.
Just having that multidisciplinary pancreas tumor board where we can talk about these issues and see, from every perspective what we can do to optimize the patient that comes through the door of the clinic. Kind of going back to the nutrition issues, I think when we see our pancreas cancer patients for the first time, we see them through a lens of someone who's lost 40 or 50 pounds. I always am asking them, do you have a previous picture? Because who they are at the point they they come through the door is really not who they've been over their life. And a big part of that's nutrition. And the basic starvation, unfortunately, of these patients. We know that pancreas cancer is a highly cachectic and type of malignancy, different than other solid tumors, just because of that exocrine and endocrine issues. And I think a big part of that is not only the absorption of nutrients and the transposition of the blood glucose to the muscles and tissues, but it's basically just stomach emptying or stomach distension. So, I think sometimes what we'll run into is at the pancreas head, it'll be compressing against the duodenum. And in those situations, what kind of options do you see, Becky, for kind of allowing there to be restoration of food to flow through? And if you can't open that up, if that duodenum is really just closed off at the pylorus, what other nutritional options are available for our patients?
So you brought up a few good points there. I think the first issue is talking about intake, how much food can you get into the body? And it can be tricky to discriminate between a mechanical obstruction and just a functional obstruction, which these patients can also have. So many of these patients will have undergone an endoscopy. So sometimes you have your answer and there's some duodenal narrowing, for example. And I think that if there's any significant degree of duodenal narrowing, these patients will benefit from a gastrojejunostomy. So in the old days, I think we would have treated gastric outlet obstruction with a duodenal stent. But in the last 10 or so years, our GI colleagues have become really good at performing endoscopic gastrojejunostomies with the lumen-opposing metal stents, the AKA Axios stents. Yeah. And so I have been impressed that these work. And I think there's some pretty decent evidence that these work better than duodenal stents in terms of symptom relief. And I can say from direct experience that it's much easier operating on someone who's had an Axios GJ than someone who's had a duodenal stent.
It's further away from the tumor. You don't have to deal with the bleeding.
Duodenal stent doesn't absolutely preclude resection, but it just makes it difficult. So I think if there's mechanical obstruction, my hierarchy is an Axios GJ would be first. If they're not a candidate for that and they're a reasonable surgical candidate, I think a laparoscopic GJ is another option, which gives you a chance to do surgical staging as well. And then duodenal stent is also in the mix, especially if maybe it's someone who's not a great candidate for a surgical procedure.
And I think that highlights perfectly that the other issue you run into is duodenal stents is you kind of almost always occlude the pylorus. Sorry, the ampulla.
The ampulla.
You always occlude the ampulla, and that prevents ERCPs, right,
Correct.
from being able to get biliary access, right? And so then you're kind of left with the percutaneous access, which obviously it's my field, but patients much prefer to have entirely internal draining versus internal or external drainage, right? And so to take that completely off the radar is not great either.
No, it's the truth. And I think that's one of the early warning signs that our patients present with is they're yellow, they're jaundiced, and then their stools are white and their urine's really dark. Why? Because that bile duct is blocked. And that bile duct blockage is able to be opened with a stent, but that can clog and that may need exchanged. And if you're putting stents in further upstream in the GI tract, you can't get back to that. And we're left trying to drain that bile, and those liver function tests need to be within a certain range for us to even give chemo safely. So we're usually turning to our interventional colleagues and say, can you somehow drain this biliary system? And sometimes it's possible, and other times its tumor burden is too high. There's just no way around it.
And, it's still feasible with a duodenal stent in there to do percutaneous drainage, but it does make our lives a little bit harder as well. So I've also seen much better results with the Axios stent than duodenal stents.
And if there is no mechanical obstruction, I liberally use Reglan, metoclopramide in these patients. I think a lot of them do benefit from that.
Yeah, and I think that, ultimately, when we're talking about kind of just the ability to eat, like you said, there's this issue with the desire to eat, in pancreas cancer. And I think we're learning more and more about that, with drugs out now, like semaglutide and Ozempic. We know that those hunger hormones come from the pancreas. And when it's injured, those hunger hormones are really reduced. Some companies are now looking at ways in which to initiate hunger. And we try to do that on our own with steroids or things like olanzapine. But I think one of the things that really blocks the ability to eat is just the malignant ascites that patients have. Basically, their abdomen is just full of fluid from the tumor, and they can't eat enough to be able to sustain their life. A lot of these patients are basically needing to eat 3,000 calories a day to keep up with the immune system, the tumor steal, the chemo regeneration issues. So, Zach, what kind of issues are available to help with that malignant ascites through the IR team?
Yeah, so I think let's even take a step back and not even just say malignant ascites, all ascites, right? And so the first thing is, the diagnosis, right? If it's a portal vein, that's just out, the intrahepatic portal veins are open, the superior mesenteric veins open. We've had a lot of success recanalizing and stenting, right? So you can get the blood flow going back to the liver, relieve the portal hypertension, and then, the ascites doesn't go away overnight, but within a month, usually they're back to having no ascites. If it truly is malignant ascites and, there's peritoneal disease that we're facing, most patients start off with a paracentesis. Really, the issue you run into with a paracentesis goes back to nutrition again. You're sucking out protein. Every single time you take the fluid out, sure, you may give them a couple grams of albumin at the same time, but it's just not the same, right? And so we know from our cirrhotic patients and the data in their cirrhotic patients, you end up with severe sarcopenia from having recurrent, peritoneal aspirations. And it really does become a huge issue from that way. So I try to get as many patients to a definitive stent as I can so they can recirculate the flow as much as they can. There have been other people, and us included with limited success, looking at something called Denver shunts or peritoneal venous drainage catheters, where it's kind of like a mix between a Porex catheter and a port. So the ascites gets drained from the peritoneal fluid through a subcutaneous tunnel and a tubing into the IJ. And then the ascites then drains into, the right atrium. And theoretically, the benefit is you get to keep all of the proteins and everything else inside your body that way. A lot of issues with that, with clogging and limited success and stuff like that. I think as our patients progress more, we do go to the Porex type catheter, where it's a tunneled catheter, just like it would be a tunneled dialysis catheter, except it drains all of the ascites that way. And the patients can do that at home, which is the benefit. They're taught how to set it up and connect it at home. So whenever they do feel full, they're able to connect and drain their fluid that way. I think a traditional misnomer was they thought that you had to be on hospice in order to get a Porex. That's actually not the case now. There is some case management and home health issues setting up that program, but most insurance companies now do actually supply, even if you're not on hospice. So if you're still receiving therapy, you can still get a Porex. And so we try and get more and more of our patients to that, so they don't have to come in and get, paracenteses every week.
And we know that, that's a resources issue. A lot of times patients may need to get paracentesis twice a week, right? And if you have every patient coming through trying to get that done and they're uncomfortable every 3 days, actually getting them in for that procedure is very difficult to schedule versus having that availability at home to drain on your own. I think a lot of what we do to try to help with this disease sometimes causes more complications, of course, right? So, things like where we're doing the celiac axis block and we're seeing diarrhea and low blood pressures and things where we do a Whipple procedure and then there's enzyme changes and endocrine changes. And even on the chemotherapy side, where we're causing things like neuropathy and GI upset. And, I think we're always shuffling the obstacles on the board with our patients, trying to kind of get ahead of it. We don't have any radiation colleagues here with us today, but we do know that, radiation can assist with pain, definitely palliatively assist with that and reducing the pain. It itself can cause fatigue. And I think the biggest thing that our patients deal with over the course of what we ask them to go through is fatigue. I think many, many times they're exhausted by what we ask of them. What ways have you seen, Becky, to kind of help patients with kind of improving their energy, getting them back out to life, helping with that either preoperatively or postoperatively?
Well, it's hard, right? I think first you want to we've talked about nutrition, but I do think ensuring that you can't have energy if you don't have adequate nutrition. If you can't restore adequate oral intake, obviously our goal is to allow them to eat on their own. Sometimes there is consideration of supplemental nutrition, either more often, usually enteral whenever possible, but occasionally we will consider parenteral nutritional supplementation if they're truly unable to eat. And then even though they're fatigued, I strongly encourage them to exercise. I think you cannot overemphasize how important exercise is for these patients.
Activity. Whatever you can do safely.
Right, because I think there's, again, really good evidence that exercise can promote your immune system and actually probably improve their fatigue. So as hard as it sounds, encouraging these fatigued patients to try to stay as active as possible.
And we know that, patients who are active have decreased risks of other issues, right? They're not going to have as many clots. The edema may not be as bad in their ankles and in their legs, and kind of staying more active opens up more opportunities for things like clinical trials that are coming out. And we do know that even some of these trials that are coming out are not necessarily anti-cancer therapies anymore. They're actually symptom improvement therapies. And I think that that's been lacking in the field for quite some time. And again, because of all of these issues, our patients will only do better if we take care of all of these conglomerate of problems. I think the biggest thing we obviously run into with this are patients that are just psychosocially depressed, because the diagnosis, the connotation for the longest time has been really, really negative. And when we can help them or we can relieve some pain or give them a clear path, I think it really helps out. Becky, when you are seeing patients kind of in consultation for the first time, how are you kind of dealing with the aspects of maybe anxiety, depression, anger, fear in our patients?
Yeah, I mean, it's difficult in our limited clinic capacity where we can only, we can't spend unlimited time with these patients. I think I try to make sure I understand what their family situation is, like who's there with them, who is their support network. We're lucky that at UCSD we do have resources that we can offer to patients in terms of counseling and peer support groups. So we try to unite them with the right resources.
No, I agree. I think having kind of that comprehensive team right up front, with our pancreas social worker, Holly, who's fantastic. We have our nurse practitioners that are dedicated to the pancreas population, psychology and psychiatry, patient support groups. I think it's all very important. I think the other part is just letting folks know this is reasonable. This is a shock,
and that they're having a normal reaction to
You're not alone,
a bad situation.
Right? We see this happen each time. So, Zach, when folks come to you and they're expecting a specific symptom relief and they get it, I'm sure they're just ecstatic. What about the situations where a patient has an expectation to get a relief and they don't get it? Does your team kind of go back again? Do you usually say, well, that door's closed? Kind of, how do you deal with kind of the pain blocks, the clots? Are there opportunities down the road where you can try again?
Yeah, totally. So like you mentioned previously, right? It's all about level setting when you first get started, right? So when I meet a patient, let's deal with pain, because I think that's the most straightforward one for us. You try, like I said in the beginning, get a history of what's the cause of the pain, but oftentimes it's blurred, right? They may have a huge pancreas mass, but they also may have a spine thing going on. And you may say, okay, I think this is what it is, but it's going to be a little bit of both diagnosis and therapeutic, right? So we're going to try a block. We're going to try blocking these nerves going to this location. I think this is what's causing it. That's why we're going to start with this, but I can't promise, right? And then we can always come back and then kind of keep trying to tackle it, right? And so you set that expectation up front that this is going to be a little bit of a guessing game as we're going. And then also you say, we may uncover additional sources of issues once you fix the big problem, right? They may have such excruciating pain from the pancreas mass that as soon as you fix it, they're like, oh my gosh, I didn't realize my back
Now
hurts.
I noticed.
Right?
Yeah.
Right? And so it's a little bit of kind of playing a whack-a-mole, right? And so the way I always describe it to one of our patients is it's the beginning of a friendship, right? Like it's not going to be just a one and done. We're going to become friends over the course of time and go that way. What I particularly like about our current setup, and I think I wish more places would do it, is that all of our clinics are in the same place, right? And so I can see someone and talk with you or you on the same day, right? And say, okay, we figured this, but now this is the problem. What do you want to do next?
Right.
Or we'll even see the patients together, right? And I think it really helps. So the patient has to keep coming back and it's a little bit not, I'll go talk to doctor, whoever. It's, okay, like we have a game plan right off the bat.
Yeah, I think, being part of a pancreas cancer kind of program that we have, the communication, the open communication, I think is so vital because we can make real-time decisions for our patients. So like you said, they don't have to have that fatigue of coming to appointment after appointment after appointment and having the video appointments, and I think really help out as well. But I think it's having a path for our patients. I think a lot of times folks will say, well, what's the answer? I need it now. What's the next step? And medicine is a practice. It's biology. Every patient's different. And sometimes things are like dominoes and sometimes it is fixed. And the trial and error, I think, is sometimes hard for patients to understand.
And I think that, clearly these patients feel they're scared and they feel powerless. And so giving them, I think, a lot of different tools so that they feel like they have some control and giving them lots of phone numbers, people that they can call and actually reach a human.
Right.
And so we arm them with a bunch of different contact information.
Well, there's so many ways to contact your care team these days, right? I mean, I think off the bat, you're going to be saying, all right, I can go to my appointment, I can call the phone number, but now there's the online MyChart messaging, and then as well as people will email, and some folks will even, give you a message on social media. So I think a lot of times is that we have patients interacting with us in multiple streams of communication, which is sometimes good for the patient, sometimes difficult for our teams. But at the end of the day, it's for everyone's best interest. I think ultimately, at the end of the day, having our ability to communicate as a team has really reduced the complications that we see and enhanced the patient's overall care. How do you think coordinating care could be done if you're not at a large academic setting between these different specialties? Because sometimes the surgeon is not in the clinic with the oncologist, and the interventional radiologist is maybe with a different practice. How would we deal with these complications at a non-academic center? What are your thoughts on that?
I think standardization is king, right? So, we have a pathway right now, completely unrelated to complications, but you have a new diagnosis of pancreatic cancer. The cancer center as well as the IR team worked on medication ports, right? We have a whole pathway now where they can get a port within a week or whatever.
Right.
So they can get chemo
7 days,
upset, right?
Yep.
It's a pathway, right? So when you put in the order, like this is following this one pathway, there's certain things that can be skipped, right? Another one that we worked on really heavily was gastrostomy tubes, right? Creating a whole pathway for gastrostomy tubes. And I was working with our nutrition colleagues for a lot of the pre-procedural workup they can actually do because they're seeing the patients first, right off the bat. And if as soon as they determine with the medical oncology or surgeon, whoever they're working with, that they need a gastrostomy tube, they're getting everything set up at home so that they're getting fed right away, right?
For the longest time, we had TPN, you needed to be admitted. Now we're trying to do that outpatient as well.
And so it's creating standardized processes, right? And so maybe we can't be in the same clinic together, but you can say, we created this process, this is just how it's going to go, rather than I'm going to place a referral on Epic and hope it works out, And
I think, with that perioperative chemo surgery handoff, that's vital because you want the patients to be on their chemotherapy, but then off for a certain amount of time before the surgery, but not too much time that the cancer's growing back. And then after they're done with their surgery, they need to come back to the medical oncologist to finish their adjuvant therapy. So how do you deal with that communication maybe at a center where the surgeon and oncologist are in different camps or different institutes?
Yeah, I guess I feel very grateful to not be in that situation because I imagine they must have to just work extra hard to stay in communication. Even if you're not physically co-located, I think keeping an open line of communication with the medical oncologist, if you're a surgeon, or the surgeon, if you're a medical oncologist, is absolutely essential because my personal practice, and I think this is probably what I would do, especially if I was in the community, is that I continue to follow patients through neoadjuvant therapy, just so I can, keep tabs on them, monitor their progress, and make sure that I don't miss sort of a window where I should be intervening. So I think that's probably one solution.
Yeah, having your teams kind of be up to speed about what the plan is from the beginning and then knowing when there's been a change in that plan and communicating that, is definitely very vital. I think that we've definitely noticed. I think one of the other things that I wanted to bring up was that kind of complications from therapy tend to be unexpected for a lot of patients and their families. And there might be a hospitalization that's unexpected or a emergency that's unexpected. How do you prepare your patients for those things and then try to guide them through that? I mean, when we deal with pancreas cancer, every day can be a change and it can be life-threatening. And I think the techniques that you've found or ways that you've learned to discuss with patients to kind of set up that anticipation and know what to look for.
For sure. Well, especially related to surgery, I tell patients that you should expect a complication. You should expect a complication, but you hope that it's going to be one that is manageable because I think we're very good now at salvaging complications. And I think the same is true through the neoadjuvant period. Just know that things will happen, but we will be there. We will take care of it.
Yeah, I think we try to set that expectation right off the bat. There will be an issue, and like that menu of phone numbers we want to give you, we don't want to make every appointment for you because we don't want to flood you with too many things. But the same thing is true. I don't want to go through every complication that can happen with this treatment, but I also want you to be aware of some of the bigger ones, right? Because we understand infection's a big issue. Post-operatively, we know infection's a big issue, even with biliary obstruction. And I think, knowing what a fever is and knowing what rigors are and things like that really help patients understand.
I do always I think you're right I think bile duct issues are probably number 1, 2, and 3 if in anyone who has a head tumor.
Right.
I think I do counsel my patients on what signs to look for if the stent might be clogging. I think if their gallbladder is still in situ, there's a pretty high risk of complications related to the gallbladder. So just keeping, I think, a low threshold to look for that and intervene on that in patients who have pain.
Yeah, and I think that, just the education of our patients kind of off the bat, because I like it part of that we're a team, right? We're a team with the patient. They're actually the lead. And by educating them about how to be a better teammate, it allows us all to do the best job that we can do for them.
I think one important point, I think we take it for granted at our institution because our GI team will place a metal stent at the outset. But I don't think that's standard practice everywhere. I think it's more common in someone who doesn't already have a cancer diagnosis. GI will often place a plastic biliary stent first until the diagnosis is secure. And I think, those stents are not very durable. And so I think if you have a patient with a plastic stent, we should preemptively have it replaced with metal for the neoadjuvant period.
And I think that's an incredibly important point because that's another area where there's been significant technological breakthroughs. We have covered stents now, right? So previously it was just a bare metal stent. That thing was in there until, the cows come home or a surgeon takes it out.
Right.
But now that we have these covered stents, they're easily removable endoscopically, but they can also be removed percutaneously, right? So even if the diagnosis is questionable, I still place one of these covered metal stents because it's not a permanent thing. It can be taken out.
And I think that's where we can really help out with folks who maybe are in the community is trying to say, what are our standards that we've been using? And even though they might be getting treated at a distance, these are the ways in which you can set them up for success and get the patients on the right track. I'll even go as far as to say, put the metal stent in and please get tissue biopsies for next generation sequencing. Because there's a complication that we run into, which is misinformation or no information. And nowadays with the advent of different RAS inhibitors and targeted therapies, having that genome sequencing right off the bat from the tissue is vital, absolutely vital. And I know people are worried about the complication risks of pancreatitis from maybe taking a core versus an FNA, but I would say right now that getting tissue biopsy and next generation sequencing off the bat is a higher priority than the chance of pancreatitis at this day and age for sure. Well, thanks so much for joining today, guys. I really appreciate the opportunity to talk with you both about different complications in pancreas cancer and look forward to discussing more with you guys in the future.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles, John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.